Hello and good evening. My name is Kevin Ma, working in Geistlich, Korea, and I'm your moderator today webinar. It is my pleasure to welcome you to this lecture with Professor Ki-Tae Koo today. He is a professor of the Department of Periodontology in Seoul National University Dental Hospital and an active expert council member of Osteology Foundation. This is third webinar as a part of Geistlich Jubilee Webinar World Tour 2016 to celebrate Geistlich Bio's 30 years, Geistlich Bio Guide 20 years, and over 1,000 accumulated scientific publications. Through this opportunity, we would like to share regenerative knowledge and further successful therapeutic approaches with the dentists in the world. And there is another opportunity to share your publications and successful clinical cases among dentists in the world. Please access to www.geistlich-jubilee.com and share your experiences about Geistlich biomaterials with your colleagues. Great chance to receive iPad is waiting for you. Don't miss the chance. During this webinar, you can ask questions to Professor Koo in real time by opening the question panel of webinar window. You can post your question. Professor Koo will answer the questions at the end. Now, we open the lecture with Professor Koo.
안녕하세요. Hello, everyone. We are streaming live from Seoul. It's an honor to be here today, and hope you will have a good time. Hope the time will be rewarding for you, and hopefully at the end you can have a take-home message, and hope you could incorporate this concept of extraction socket management or rich preservation to your daily practice. Okay, I would like to start with the terminology. Rich preservation, defined as preserving the rich volume within the envelope existing at the time of extraction. Now, there is a difference between preservation and augmentation. Augmentation meaning increasing the rich volume beyond the skeletal envelope. So if it's beyond the skeletal envelope, it's considered augmentation. And the message I would like to send to you is that preservation is much easier than augmentation. That is probably the take-home message of today's lecture. Okay, I have 40 minutes to persuade or convince you that rich preservation is important. So I want you to listen carefully, and hopefully at the end you could incorporate this message into your clinical daily practice. Okay, there is a second or two lagging, so please excuse. I hope you're understanding. Okay, the three good reasons to preserve are, first would be to maintain ridge height. That's probably because of the favorable crown to root ratio, and also the discrepancy between the implant site and also the adjacent bone level. So if you have a discrepancy, you would have more food impaction, and also this could lead to, I guess, peri-implantitis, a higher chance for peri-implantitis. So that would be one reason to maintain ridge height. Second would be to avoid erratic healing of extraction sockets. Erratic healing by meaning the socket won't heal by itself. Even though you debride it very meticulously and you wait a long time, it will not heal by itself. So that's what we define erratic healing. And also, the third would be to avoid dimensional changes, and there are beautiful literatures by Dr. Araujo, Cadaropoli, and also Barone, so we have a lot to talk about that. But these would be the three main reasons to preserve. So now we work with the first reason, to maintain ridge height. And here's the first case. It was done by a resident of mine. The treatment plan was to explant. I would have done a peri-implantitis surgery, but it was to explant the implants and do a GBR 2 months later, and this is what you get after 2 months. The collapse, vertical collapse of the ridge, and after 2 months, it's maybe too late to go back, and now it becomes a vertical augmentation case, which is very difficult. If you are Dr. Massimo Simeone or Dr. Urban, that would be easy, but for an average dentist, this becomes a very, very difficult task. So I guess ridge preservation might have been a better answer to this situation. So the results after 8 weeks, you see that the results are devastating. And the message I want to send out is that it's easier to preserve than build. So that's the first take-home message I would like to send. And we move on to the second reason, to avoid erratic healing. And I would like to define that again. So this is a clinical presentation of a socket after 12 months of healing. So a representation of a socket after 12 months. The tooth was extracted atraumatically and also debrided very thoroughly. And we do see the buccal walls and the lingual walls intact, so there's no reason for this socket to not heal by itself. But what we got at 12 months after meticulous debridement was that it was not filled with bone. It was filled with fibrous connective tissue, and this phenomenon we define as erratic healing from now on. So we're very proud of this paper. And this is another case of healing after 6 weeks after tooth extraction. The tooth was extracted atraumatically also, and we spent a lot of time, at least 10 to 15 minutes, debriding the area very thoroughly. And this is not the normal healing you would expect after 6 to 8 weeks. You would expect it to heal by bone, to fill up by bone, but instead we don't get bone, and we get fibrous encapsulation instead. So this is what we would define erratic healing. We are very proud that this paper was published in the JCP Digest also, and I'd like to show, because of the time limitation, I'll just show you the results of the study. And we were able to, I guess, define the characteristics of disease extraction sockets or infected sockets, as you might say. And the results here, we could say that the types of lesions that were related to erratic healing, periodontal lesions were the most prevalent. So we do see a 72% of prevalence in the periodontal lesion group, and also the number of socket wall remaining, it was most dominantly 3-wall defects in 56.52%. So we could see that 3-wall defects as the result was most prevalent. And also, the site of lost wall was more prevalent on the buccal side compared to the lingual or the palatal. So these are the characteristics of disease extraction sockets we were able to see in our study. Yeah, and we do have some lagging. And then I would like to move on to the third reason, to avoid dimensional change. And I'll just quote several second-generation studies. The first-generation studies were published in 1967 by Dr. Emle and Piotr Skovki. And these are the second-generation study. And it was a rather simple study done by Dr. Schroep. And it was done in 46 patients. So what they did was, before and after extraction, with alginate impression, they were able to make model casts, and using a caliper, they measured the changes, the resorption, and the dimensional changes horizontally. And the results we were able to see was that most of the resorption occurred during the first month, 3 months, which is remarkable. And second result they were able to see is that approximately 50% reduction of the ridge width was observed. That's quite a lot. And the mean change after 1 year was 6.1 millimeter, which is quite remarkable also. So the horizontal dimensional change is well put by Dr. Schroep. And now we move to the vertical changes. This study, I think everybody knows, it's very famous. It was done by Dr. Araujo. It was done in beagle dogs. And what they did was they just extracted tooth, and they were able to make histological sections at 1 week, 2 week, and 3 week, and 4 weeks. And what they did was, using the histological sections, the blue line you see on the screen is the connection of the highest point of the lingual crest. So when you connect all the lines, you could see that there was minimal change or minimal dimensional change in the lingual crest. However, when you see the green line that are connected, that's the highest point of the buccal crest. So when you connect that from 1 week to 4 weeks, we do see some loss, averaging about 2.6 millimeters, and this is the famous bundle bone theory by Dr. Linde and Dr. Araujo. So we do see a 2.6 millimeter of horizontal, vertical resorption concentrated to the buccal side. So this is the bundle bone theory, and I would like to show you a clinical case. This is my case. A left central incisor with a root fracture. So what we did was we extracted the tooth, and we waited 4 months to see the results. And my choice would have been early implant placement, but this student of mine just decided to do a delayed implant placement. And this is the resorption you see at 1 month. Quite remarkable resorption, both vertically and horizontally. And this becomes even more pronounced at 4 months. Look at the slides. If you could see the slides on the right side, the resorption in the vertical and horizontal dimensions are more pronounced and I guess more exaggerated, I guess. So this is the type of healing you see without preservation, and this, I think, sends out an important message that rich preservation is very important. Now we come to a clinical study by Dr. Matarazzo, and this is basically what they did. What they did was they placed an implant that was standardized in dimensional and length, and they placed it in the septum. So they atraumatically extracted the tooth and they debrided the area very thoroughly, and they placed the implant in the middle at the septum. And what they did was, within the space that was available in between the buccal aspects and the implant, they filled it up with bios, and they used bios collagen for secondary intentional transmucosal healing. And the results we see. So this is pretty much everything you would do to prevent resorption, the buccal resorption. And despite all this efforts we did for to prevent resorption, okay, we are seeing some lagging. Okay, these are the results we got after 6 months at re-entry, and the vertical change was minimal, both on the buccal and lingual aspects. However, for the horizontal change, it was more pronounced at the buccal dimensions. We see a mean of 2.67% of 6-7 millimeter of resorption on the buccal side. On the lingual side, it's minimal. So this sends us a message. They concluded that even though we attempt to do a lot of things to prevent resorption, resorption on the horizontal dimension is inevitable in some way. So this is one message we can get from this very well conducted study. Now I'd like to show you a case of mine. Okay, we having a lag, okay. Now we place the implant in a 3-dimensional position towards the cingulum also, and then we make a custom abutment, and we fill this area with bios, which has this non-resorptive qualities. Also, we use BioGuide to cover up the area. And this is the healing you get at 4 months. Despite all the activities and the efforts we use to prevent resorption, we do get resorption supporting the bundle bone theory. So this is one area we have to think about. And I would like to move on to the studies that are done in infected sockets. So until now, everything was done in fresh extraction sockets. And my research since 2012 have focused on infected sockets also. So we're seeing a switch from extraction sockets, fresh extraction sockets, to infected sockets, which we see more common in our daily practice. And the reason for extractions probably are more related to infected extraction sockets versus the fresh extraction sockets. So one of the most frequently asked questions I would like to answer this way. The question would be, how do fresh extraction sockets differ from infected sockets? And I have a list of reasons for that, and I'll show you and I'll explain one by one. The first reason, oh, excuse me. Okay, sorry for that. Okay, the first reason would be that infected sockets are less predictable than fresh sockets, and also they're closer to chronic inflammation, and they do show the clinical signs of inflammation, which are swelling and also pus formation and acute pain. Also, they have pathology involved, whether it's endodontic, periodontal, or combined, and accompanies radiographic radiolucency that are quite large in size, and also shows destruction, loss of bony walls, loss of soft tissue, and also loss of self-healing potential or regenerative potential with severe resorption. Also, the reason for erratic healing may be because it has changed to a necrotic bone, and we do observe sclerotic changes in bone when they have chronic lesions or chronic lesions surrounding the area. They are usually adaptive properties that have thickening of bone around the chronic lesions. Also, soft tissue infiltration instead of bone after ample amount of healing time that usually clinically translates to loss of precious treatment time for the patient and also for you as clinicians. Now, I would like to show you the technique. The title is Show Me the Technique. So here is a case of mine. Okay, swelling and pain on number 36, which is the first left mandibular molar, and the clinical findings were swelling, pus discharge, and deep probing depths on mid-buccal furcation area. So you could see that the probe is penetrating deep into the pocket, and this is what we do. Normally, we could dissect a tooth for atraumatic extraction also. In this case, we extracted the tooth atraumatically and used BIOS collagen plus double layer of BioGuide to do the ridge preservation procedure. So the tooth was extracted. And then you could see that the lesion over there in the left-hand corner. So I usually spend a lot of time, at least 10 to 15 minutes debriding the area, because all the preservation procedures are done in an immediate fashion. So you do have to invest a lot of time trying your best to eradicate or clean out the area very thoroughly. And this is what we did. And then we grafted the area using BIOS collagen, and then always a double layer of BioGuide. And we now, because of the ample evidence, we now use the double layer of collagen membrane, BioGuide, and and the flap to cover it. However, there is a difference between flapped and non-flapped protocols, and actually the flapless procedures are showing better results. So nowadays, using the open membrane technique mostly. And this is the healing you will see. Immediate post-op, okay, and then 1 day, a slight sloughing at 1 day, and we could see the clot formation, which is pretty nice. And we move on to 2 weeks and 4 weeks of healing. A little bit of tissue loss at 2 weeks, but that's okay. We do see some rebound at 4 weeks, and at 4 months, we could see that horizontally we are able to withhold all the volume, and also a nice zone of keratinized tissue formed. But at 9 months, we do see some resorption on the buccal side, and that's probably because of the flap elevation that was performed at the time of surgery. So that's one reason we can think of. So this is healing the lateral view at 1 day, blood clot formation, and at 2 weeks we do see some tissue loss at 2 weeks, but at 4 weeks we are seeing a little bit of rebound, and then it goes on 4 months and 9 months, and we were able to place the implants. The patient did not show up until 9 months. That's why we placed the implant at 9 months, but normally I place the implants after 4 months. So we are able to see that the integrity of the volume and the ridge height is being maintained very well. And this is the bone at 9 months. The quality was really good. It was D1 or D2, somewhere in between there. So a very good site, well-prepared site for implant placement. And I'd like to show you some X-rays to just compare at the initial time of surgery and the time after at 9 months. We could see that the volume and also the height of the ridge is maintained very well. And we could see the 3-year follow-up of the patient. Also another X-ray showing well-maintained ridge height and clinical presentation of that. However, on the buccal aspect, we see that we do see some slight resorption, and probably due to the flap elevation. So these are the results at 3 years, and quite nice results. Okay, and I'd like to move on to to more reasons to preserve. Okay, the first extra reasons, I guess, would be to increase zone of keratinized tissue. And we know that we could achieve this through the open membrane technique. Dr. Kadaropoli has a very nice paper about this. And the second would be in soft tissue deficient defects. So these are defects that have gingival recession also. So in these cases, it would be impossible, quite impossible, to place the implant immediately. So we have to go delayed. But because of the soft tissue deficiency also, I guess ridge preservation would be a very good indication to treat this kind of this kind of defects. So this is a study by, okay, slight lagging. This is a study by Dr. Kadaropoli, and it showed that open membrane technique is very rewarding and also very promising, very predictive results, showing good keratinized tissue and also minimal resorption on the buccal side. So I think this is a very good reference we could use to justify the reasons for open membrane technique. And let's look at some of the more severe defects, including soft tissue deficient defects. And I'd like to share with you a case of mine showing this type of defect. Okay, here on the buccal side, you could see that there is bone loss halfway to the middle of the root, and also buccal gingival recession. So in this type of defects, it becomes much more challenging, and you need to go in a delayed fashion. You need to you need to perform the ridge preservation, but at the same time, simultaneously, you need to do a soft tissue graft outside. So I'd like to share with you this case. Okay, we extracted the tooth immediately, and we made a bilaminar flap at the base, and this we used a BioOs collagen. And the reason I like to use BioOs collagen in this case is that you could actually customize the size, and it perfectly with the blade we could trim it and customize the size, and it perfectly fits into the defect site. And also it's like a cube sugar, so you could use it very wisely. And the next slide, we cover that up with a collagen membrane, and we harvest a connective tissue graft from the palate, and with the bilaminar flap we are able to cover it. And this is a healing you get after 4 months before implant placement. We do see some scar tissues, but it was inevitable because we had to save the papilla on the cuspid, distal aspect of the cuspid. So we did make a vertical incision, and you can see the volume of the area that is saved very nicely. So this is preserved bone at 4 months, and now we place the implant at 4 months. Okay, and this is the result before and after. So not 100% perfect, but I would say there is quite a remarkable advancement or improvement in the aesthetics of the patient, and patient actually enjoyed and was very satisfied. So we were satisfied also with the results. So the take-home message in this case would be this is the X-ray at 1 year. The take-home message is that in a very challenging cases like this, ridge preservation would be a very good answer. If you could combine that with additional soft tissue augmentation, that would even be much more better. So that's my take-home message for this case, this type of very challenging case. So the next question would be, do we need a membrane at all? And this, I guess, clinically, for clinicians, this questions come up very frequently. And my answer is yes. Yes, we do need a membrane. And I would like to answer this by a study that was not published, accepted 2 months ago by our group. And basically what we did in beagle dogs was that in one group, we used BioOs collagen alone, and the other group we used BioOs collagen plus BioGuide, the collagen membrane. And we made an experimental study in dogs comparing the group, and just because of the time limit, just to briefly tell you the answer, the BioOs collagen and collagen membrane group showed the best results regarding mineral contents, so mineral density of bone, and also there was less collagen and fibrous tissue in test group 2, which is BioOs collagen and collagen membrane. So this group, I guess, because the first reason would be wound protection. That would be one good reason. The second would be prevention of migration of biomaterial. And another reason would be, I guess, the affinity of collagen membrane with the cells. So maybe this is just a hypothesis, but I have heard Dr. Omar from Sweden talk about the crosstalks between collagen membrane and the cells, and it was quite interesting. So I think we have more research to be done in this manner, but definitely we do need a collagen membrane covering the biomaterial. Yes, my answer is yes. Now, another frequently asked question is about soft tissue closure. What do we do? Do we need to close their area? And there was a beautiful study done by Dr. Jung from Zurich. Okay, and initially, I guess he's been using a palatal punch, a free gingival graft to cover the area. But the problem in this case is patient morbidity. The patient feels very uncomfortable. It is very painful. So one alternative I would like to use is mucograft seal. So this is a case done in the anterior region. And this is a BIOS collagen. We filled the area. Maybe we filled up too much in this case, but we filled the socket with BIOS collagen. And in this case, when the walls are intact, both buccally and palatally, I love to use mucograft seal for soft tissue coverage. And this is a figure 8 suture or a cross-sectional suture to hold the mucograft seal in place. And this is the healing you see at 2 weeks. You can see that epithelium is forming very quickly. And another slide at 4 months. You could see that the ridge is pretty fat and the volume is good. So I guess this was a very successful ridge preservation procedures. So in cases where the walls are intact, I like to use mucograft seal very much. But in case we have dehiscence or a breakdown of the buccal walls, in some cases, I guess you have to use double membrane collagen membrane, or BioGuide, as you say. So that would be my answer. If we should use the membrane at all, yes, my answer is yes. Okay, now another question asked was, is ridge preservation safe? And when you look up the literature, there is not much evidence actually showing this type of data. And another study done by our group. So we went back retrospectively, and we are currently working on this paper with my dear friend Frank Schwartz from Düsseldorf. And the title is Ridge Preservation, is it safe or not in infected sockets? So now you could see that we are focusing and moving on from fresh extraction sockets, moving on to infected sockets. And basically, what we did was the patients who came to our clinic, Seoul National University, from 2011 to 2015, we were able to gather 320 patients who had received ridge preservation procedures. And we included 3 doctors for this case. And out of the 320, 13 did not meet the inclusion criteria. So only 307 met the inclusion criteria. And to keep it short, out of the 307, only 2 have failed with infection. So 305 out of 307 ridge preservation cases were successful, showing a success rate of 99.35%. That is quite remarkable, I may say. So we are almost finishing up the paper. We'll publish it soon, and we'd like to show that 80% of the biomaterials used were BIOS. So that's another significant finding, I guess, we could declare at this moment. Okay, now another frequently asked question: why do we preserve immediately, or can we do it in a different way? But I like to do it. I like to preserve immediately after tooth extraction, and the reason would be, there are 3 reasons. The first would be it's much easier that way. It's much easier. The second would be utilizing the soft tissue we have at the time of extraction. We don't want to lose it. So soft tissue loss after we wait, I think that's a concern for us. So this is why I like to do immediate ridge preservation. And also the third reason would be regional acceleratory phenomenon, saying that after you have trauma, the healing cells or healing potential is actually boosted in the site of trauma. So I guess because of the acceleration of healing potential, this may be the reason for immediate ridge preservation. I'd like to share with you another case done by my resident, and they decided on the lower right, the mandibular right implants, they decided to explant the implants again, and do a GBR 2 months later. I think it was wrong. They could have just done a periimplantitis surgery or removed the first implant only, but they decided to do anyway. And this is what you get. The consequences of not performing ridge preservation is quite severe. So this is the resorption you get. And the point I would like to make is that resorption occurs really fast. It occurs much faster than you expect. So this is quite a devastating result we could see. Clinically, this is what you get. So now you see the thin ridge we could see, and now it becomes a vertical augmentation case, which is very, very difficult. So I would have preserved the ridge, and we could have had a much easier life. Now it becomes a vertical augmentation case. So the consequences of not doing anything are quite severe. So this is my message to you today. I hope the message gets across. So yes, this is the reason why I perform immediate ridge preservation. Now, another question that is frequently asked, do we wait at all? Do we do immediate preservation all the time? No, my answer is no. In some cases, we have to wait, and I like to show this X-ray. It's quite a good representation of the justification of why we wait. The lesions are quite large, and also if the lesion or the infection is very severe, and also if it's very acute, I would like to wait. And also if the lesions are very severe and in close proximity to very important anatomic structures such as the nerve or the sinus floor, I would like to wait. And how much do I wait? I wait maximum of 2 to 3 weeks. Why? Because if you wait more, you lose too much structure. You lose too much soft tissue, too much bone, as you saw in the previous slide. So I don't like to lose that much soft tissue. So yes, I would wait, but maximum would be 2 to 3 weeks. And also 2 ways to approach this. One way would be you could postpone extraction and actually prescribe systemic antibiotics to the patient and actually let the infection subside and then go back and extract the tooth and perform the preservation procedure. Another would be extracting the tooth and actually debriding, not 100% thoroughly, but enough, and then putting the patient on systemic antibiotics and coming back 2 to 3 weeks later and actually finishing off the debridement. That's two ways approaching this type of infection, which is severe. Now, there is an issue about host factor. Does host factor matter? And my answer is yes. And I would like to show you this case. Okay, we did a ridge preservation procedures. We used a BioOx collagen, BioGuide, double-layer BioGuide, and an open membrane technique. And you'll be quite shocked with the results. And if you see the slide in the middle, this is the healing we got at 2 months. So we thought it was a cancer patient, but no, it wasn't. That's a joke. But the patient, going back to the dental history, was a chronic smoker, smoked 2 packs of cigarettes every day, 10 cups of coffee every day, and not sleeping more than 4 hours every night. So this is the healing we get at 4 months, but eventually the slide next to it, you could see that the healing does start after 2 months, and eventually it healed after a couple months. So yes, there is an effect, host response effect, but if you use the right biomaterials, I think you are able to overcome this. So this is, I think, probably the most severe case we saw. Okay, now we are approaching the end. Now, one hypothesis I would like to throw at you, I would like to challenge you, is that can we combine preservation and augmentation? And I'd like to just briefly show you one case. Okay, this is, I guess, a mixture of, we do see preservation on the left, but we do have the flap at the CJ. So it becomes a combination of preservation and augmentation. And I'd like to just clinically show you this case, run through it really quickly. Okay, we see the X-rays. Okay, big lagging. Okay, so what we did was we extracted the tooth, meticulously debrided the area. The case in the lower does not have any buccal or lingual wall. The one above has buccal and lingual support halfway to the root length. And what we did was we used BioOS collagen to graft the area, placed the double membrane over that, and left it to heal with the open membrane technique. And this is the healing we got at 4 months. 4 months, and we were able to place the implants. And this is the healing with the second stage surgery and after the prosthesis connections. So this is the healing at 1 year, 1 year with the prosthesis. Not the best prosthesis, but okay, you have to accept it anyway. And radiographic presentation at 1 year. So yes, I need to convince you with more long-term results, but until now, it showed promising results, and this hypothetical question is answered. Yes, maybe we can combine augmentative procedures with the preservation procedures. Now, this does have its limitations, and I'd like to share with you some limitations. The limitations is that if you extend it from a single case to multiple case, we do see some collapse of the membrane, also tearing of tissues at the crest area. So this is one area I think we need to solve if we are to extend it to a multi extraction case. So yeah, this is one area we need to work on. One solution that came to our mind was that using a combination membrane technique, using a collagen membrane and a more rigid membrane over it, but it's still a hypothetical question. So yes, we need to do more research in this area. Now I would like to, it's a 40-minute presentation, so I'd like to finish by stating that in infected sockets, it is different from fresh extraction sockets. We were able to observe erratic healing. Also, the characteristic features we saw. Also, in the healing phase, because surrounding the chronic lesions, we were able to see sclerotic change and also delay in healing in infected sockets, and also compromise in healing and loss of osteogenic potential. So, dear colleagues, I would like to summarize, and this is the take-home message today. Preservation of the initial soft tissue volume is now becoming the issue, and also a method to completely eradicate infectious remnants at the time of tooth removal is necessary. A clinical protocol or guide using biocompatible biomaterial at the initial stage is necessary, yes, necessary. Even with the progress and advances in the socket preservation concept, more research is needed to make the standard for this procedure. Now, it is more difficult to rebuild tissue, bone, or soft tissue than preserve. That is the major take-home message today. Therefore, caution must be exercised during treatment planning, and also everything I said today clinically translates to loss of precious times, both for you, the clinician, and for the patient. So I guess it is very important in some patients to incorporate this type of concept into your daily practice. Okay, I have some advertisement. Okay. Now we talked about the clinical aspects of ridge preservation. We have made a classification system and treatment protocols for infected extraction sockets, and this is just to show that the infected sockets are very diverse. So the approach to this would be it shouldn't be done in a single manner. So we needed a classification and treatment concept to treat all the infected extraction sockets. So it's coming to EAO 2016, and this is just to briefly show you the type of infected socket classification. So with this is all I have for you today, everyone, dear colleagues, and I thank you for your attention. Thank you very much.
Okay. Thank you very much, Professor Koo, for your excellent presentation. And then now we will now enter into the Q&A session directly. Okay. So I collect a couple of questions from the attendees. The first question is you mentioned about the erratic healing during your presentation. So
yes.
The first question is, how many erratic healings can be observed in our clinical settings? Do you say that?
Oh, yeah. That's a very good question. I think, okay, we previously reported through our, we have a report that was published in Journal of Clinical Periodontology in 2013 about erratic healing. And at the time, our incidence was 5.41%. However, based on my clinical experience and actually this becoming the issue, we are seeing more relevance to erratic healing. So I would say the number is much higher than 5%, so much more higher. And I guess as we learn more about erratic healing, I think the number will go higher, go up.
Okay, I see. And the next one is regarding the membrane. So you already mentioned about the membrane usage in your presentation. So the question is, should we use a membrane for the ridge preservation procedures?
Oh, definitely. Yeah, we answered it through our publication that was accepted 2 months ago in COIR. But yes, membrane has to be used. I repeat this, the first reason would be wound stability, because of wound stability, wound protection at the initial stages. And the second would be to prevent the escape of biomaterials or migration of the biomaterials. And the third issue that came up by Dr. Omar from Sweden, a crosstalk or a gene expression was observed in the collagen. So the collagen membrane itself has affinity to cells. So we don't know exactly what happens, but I guess there is some interaction between the two, and we need to explore that more later on in research. So that is a very good question. Yes, thank you.
Yeah, your message is very clear. Yeah. And then the third one is regarding the primary closure. So so actually this is a kind of a headache among the dentists actually. So should we achieve the primary closure after bone grafting?
Actually, there are a lot of studies supporting this open membrane technique, which is done in a flapless manner. So, and Dr. Kadaropoli, Dr. Barone, and there's another study being done in Korea by Dr. Park, and we are actually showing excellent results without primary closure. So, actually, in a lot of the cases, we do not really actually need to raise the flap. So we perform a what do you call it? Open membrane technique. And another advantage of performing a open membrane technique is that you get a nice zone of keratinized tissue. When you are trying to achieve primary closure, you pull up everything, and the zone of keratinized tissue decreases.
Yeah.
So I guess if we perform open membrane technique, we are able to acquire that good zone of keratinized tissue, and that would be another advantage, yes, for the open membrane technique.
Okay, I see. Then there is another headache question among the dentists, actually, because this question is related on the patient management, something like that. Because actually, the patient, no patient want to wait for a long time for the final procedure. So this is regarding that. So how much time should we wait before placing the implant placement?
Yes, actually, there is no qualitative analysis that was done to support this, but from a clinical point of view, I guess you need at least 4 months. So in my case, I wait 4 months to go in and place an implant. If you are, and I think it's related to your learning curve also. If you're not comfortable placing an implant at 4 months, I guess I could recommend that you wait, a little longer, maybe 6 months, and you would get definitely better bone. But at least 4 months from a clinical judgment, and we need to do a qualitative analysis, I guess, regarding this subject. But yes, I think 4 months would be a good answer.
4 months, okay. Then the next one is this is very practical question. In the cost aspects, also this is very important to the dentist. So which one is more profitable for the dentist among the extra circuit management and GBR?
I guess because socket management or ridge preservation, it's easier. I guess if you could handle the infection very well, and if you do it in an immediate manner, I think it's easier. So there is, because of the cost issue, if you are confident with GBR, that's fine with me, but the question is, can you finish it at once? I mean, is there a chance that you might have to come back and do another GBR?
Yeah. So
regarding that aspect, I think it's easier and much more profitable doing the ridge preservation in an indicated case, I guess, compared to GBR. So I guess it's a personal preference for the clinicians, but in my case, I feel much more comfortable with the ridge preservation procedures.
And then there is another very interesting question from the attendees. So you mentioned about the BioGuide for membrane for your clinic, as well. Can you use the collar tape instead of the BioGuide?
Collar tape or collar plug? I think that's a good question. I would only use it for cases that have intact socket walls, both buccally and lingually. Yes, maybe that could be a replacement for mucograft seal, maybe a membrane, but in severe cases when you have disruption of the buccal wall, lingual wall, and in more severe cases, no, I would not recommend using collar tape. Collar tape and collar plug will only be indicated or recommended to be used in cases where there is minimal resorption and intact buccal and lingual wall. It's a very good question. Thank you.
Yeah, okay. Then, as I know, you are still researching about ridge preservation and extraction circuit management. So,
question? I think we could go to the number 6.
Yeah. We go that first. Okay. Do you routinely prescribe antibiotics for either fresh or infected site?
Yes, especially for infected socket. Yes, we need to prescribe systemic antibiotics, and I prefer to use one of the stronger ones. So Augmentin, Augmentin would be one good choice. Another would be from the third generation Cepha group. So I don't think amoxicillin itself would be enough. So I guess you need to go with something more potent, more powerful. So one recommendation I could give you is using 625 milligrams of augmentin, which is 500 milligrams amoxicillin, and 125 clavulanic acid. So yeah, so a combination of that would be, I think, very helpful. And like I told you before, you could use it either to actually subside, so you could postpone extraction and prescribe first, so that you could subside the infection. That's one way. Another way would be extracting the tooth and debriding, not 100%, but trying hard, and then prescribing antibiotics for a week or 10 days, and coming back and finishing off and performing your ridge preservation procedures.
Okay, thank you for your very practical answers. And then, as a last question, may I ask about your research now and the future plan?
Future plans, yes, we have adopted and we have created a classification system, and we are going to show that. At EAO. So it's going to be a debut for that classification. The hands-on workshop is sold out. So yes, thank you very much. But yes, that's my future plan, and then we will go from there, and we will actually, I guess, go deeper into the infected socket issue. So we have a lot to explore from now on, and my research will concentrate in that area.
Yeah, congratulations for
thank you very much. Thank you.
EAO the workshop. So thank you, Professor Koo, for your great and informative answers. There are still a few questions left, but unfortunately, we are running out of the time to answer all the interesting inputs. Thus, the remaining questions will be answered by follow-up email. If you want to learn more about our product, therapeutic areas, and your local leader, please access Geistlich website www.geistlich-pharma.com. You can find further information about Geistlich on the website. Yeah, we wish you enjoy the rest of the day or evening, and we are looking forward to our next webinar, which takes place on September 15, 2016, 7 p.m. in Brazilian time. In that webinar, Paulo Fernando from Brazil will address the topic of soft tissue management in Spanish. Okay, we are now at the end of the third webinar. So we hope you have enjoyed this session and found a good solution for your daily practice. The presenter was Professor Ki-Tae Koo in Korea, and my name is Kevin Ma. Thank you very much for your attention. Goodbye.
Goodbye.